Welcome to the deep dive. Today we're plunging into a topic that might sound quite specific at first glance, but I promise you, its implications stretch across global health and even touch the air we breathe every day. Aspergillosis. We've got a fascinating, really comprehensive medical chapter to unpack here, aiming to give you a truly deep understanding. You know, the kind that empowers you with a mastery of the subject far beyond just surface level facts.
Right, getting to the real detail.
Exactly. Our mission for this deep dive is pretty straightforward: to distill everything you need to know about aspergillosis, pulling directly from chapter 217 of a robust medical text.
Yeah.
This isn't about memorizing lists. It's about connecting the dots, understanding the fundamental nature of this disease, its surprising reach across the globe, who's truly vulnerable, how it manifests in the body, and the most effective ways we're learning to combat it. Think of this as your personal expedition to mastering a complex yet crucial area of infectious disease, equipped with, hopefully, some surprising facts and practical insights.
What's truly fascinating about aspergillosis, and this is a crucial foundational understanding, is that it's not really a single disease.
Right.
It's actually a broad term. It encompasses a whole range of conditions.
Yeah.
And all of them are caused by different species, roughly 50 of them, from the Aspergillus mold family.
50. Wow.
Yeah, quite a few. But the key distinction, and something we really must understand up front, is that only those specific Aspergillus species capable of thriving at human body temperature that's 37 degrees Celsius are the ones that can cause invasive infections.
Okay, so temperature is key.
Absolutely. The others, the ones that prefer cooler temperatures, they primarily lead to allergic syndromes, not direct invasive disease. Big difference.
Read it.
Now, quick simplification just for our discussion today. While many of these common pathogenic species are technically a complex of various cryptic, closely related species, for clarity and focus, we'll refer to them simply as single species. It just helps us focus on their distinct roles and what they tend to do.
Okay, makes sense.
So let's introduce the main characters in this story. The undeniable central figure is Aspergillus fumigatus.
Fumigatus. Okay.
This is the primary culprit. It's responsible for the vast majority of invasive cases, almost all chronic cases, and most allergic syndromes. If you remember just one Aspergillus species, make it this one.
Okay, Fumigatus is number one.
Then we have Aspergillus flavus. This one is seen more frequently in particular hospital environments and is often implicated in specific types of infections, like those affecting the sinuses, the skin, what we call cutaneous infections, and a serious eye infection known as keratitis.
Keratitis, right, eye infection.
Exactly. Next is Aspergillus niger. Now, while it can cause invasive disease, you'll more commonly find it simply colonizing, just sort of residing harmlessly in the respiratory tract, or causing external otitis, those uncomfortable outer ear infections.
Looks like swimmer's ear type stuff.
Sometimes, yeah. And a particularly unique and concerning species is Aspergillus terreus.
Terreus. Okay.
This one almost exclusively causes invasive disease. And sadly, when it does, it often carries a very poor prognosis. So it's a critical one to identify.
That sounds serious.
It is. Finally, there's Aspergillus nigilans. This is an occasional cause of invasive infection, primarily observed in patients with a specific inherited immune disorder known as chronic granulomatous disease, or CGD.
CGT, okay.
Understanding these key players is really your first step to truly grasping the diverse challenges posed by aspergillosis.
So, knowing these key players, let's explore where they actually live. Here's what truly puts Aspergillus on the map globally. This isn't some rare jungle fungus you'll only find in exotic locales.
Not at all.
It's quite literally in the air you're breathing right now, no matter where you are on Earth. Think about that. A mold that plays a vital role in decomposing your garden compost pile can, under specific circumstances, become a life-threatening pathogen inside the human body.
It's quite the contrast, isn't it?
It really is. The profound insight here is the sheer ubiquity of a potential threat that mostly, thankfully, flies under our radar. Its favorite haunts are decomposing plant materials, like those compost heaps, and surprisingly, it's even commonly found in bedding, which underscores its natural role as a decomposer in the environment.
Exactly. Part of the natural cycle.
And when we talk about the mold itself, visualize it as a hyaline, which simply means non-pigmented or clear, a septate, meaning segmented, and branching mold.
Okay.
The key to its widespread presence is how it reproduces. It produces vast numbers of tiny reproductive units called conidia, or spores,
The spores, yeah.
which are essentially its airborne seeds carried on stalks that extend above the surface of its growth.
Like tiny little fungal trees releasing seeds.
Kind of, yeah. So where will you find these pervasive spores? Truly everywhere. They're in indoor and outdoor air, on surfaces all around us, and even in water from surface reservoirs. You are quite literally encountering them constantly, whether you realize it or not.
And you're absolutely right about that constant exposure. On a daily basis, individuals can be exposed to anywhere from a few to many millions of Aspergillus canidia.
Millions, really.
Oh, yeah. You'd encounter particularly high numbers in exceptionally dusty environments, like, for instance, a hay barn, where the air is just thick with these spores.
Okay.
Now, the exact number of spores needed to cause disease, what we refer to as the infecting inoculum, isn't precisely known. However, the source clearly states a crucial point for healthy individuals. For otherwise, healthy, immunocompetent people, only intense exposures.
Intense, okay.
Think about situations like active construction work, especially demolition, handling large quantities of moldy bark or hay, or active composting. Only those situations are typically enough to cause acute pulmonary aspergillosis.
So for most healthy people, everyday exposure isn't the main worry for acute infection.
Generally, no. It highlights that for a healthy immune system, it usually takes a significant, overwhelming spore load to overcome the body's natural defenses and lead to an acute infection.
Right.
For allergic syndromes, the mechanism is a bit different. Here, continuous exposure to the mold's antigens, the substances that trigger an immune response, such as from the mold colonizing the sinuses or airways, or even a persistent nail infection, can constantly stimulate the immune system and exacerbate these allergic conditions.
So even a small amount, if it's persistent, can cause allergic issues.
Exactly. It means even a seemingly minor localized presence of the mold can contribute to ongoing chronic allergic reactions.
Okay.
A practical protective measure that's paramount, especially in medical settings, is high-efficiency particulate air, or HEPA, filtration.
HEPA filters, right.
These specialized filters are vital and should be meticulously installed and monitored for efficiency in critical areas like operating rooms and other high-risk zones within hospitals. This is a primary strategy for minimizing environmental exposure in our most vulnerable patient populations.
Absolutely critical in hospitals. The timeline for infection and acquisition and invasive aspergillosis is, well, surprisingly wide-ranging.
It really is.
We're talking about an incubation period that can stretch anywhere from a mere 2 days
2 days.
to a full 90 days in documented cases. This broad window has significant implications, especially when doctors try to trace where a patient might have picked up the infection.
Makes it very difficult.
It does. It means that an infection initially acquired out in the community can frequently manifest as a severe invasive disease during a patient's hospital stay, making it tricky to pinpoint the exact moment or location of acquisition.
Right. Community acquired versus hospital acquired gets blurry.
Exactly.
Okay.
However, it's also quite common for patients to acquire the infection directly within the hospital environment itself, what we term nosocomial acquisition. And when outbreaks of aspergillosis do occur, they are almost invariably linked to a contaminated air source, like a compromised ventilation system, or to active construction work happening within the hospital.
That instructional link is a classic one, isn't it?
It really underscores how critical environmental controls and vigilance are in healthcare settings.
If we truly connect this to the bigger picture, the global burden of aspergillosis is significant, and its specific manifestations can vary considerably by geographic location, which is a key insight.
Okay.
When we look at the estimated global incidence and prevalence from the sources table 217-1, the numbers are quite staggering. For invasive aspergillosis, we see an annual incidence ranging from 0.6 to 16 new cases per 100,000 people.
0.6 to 16, that's quite a range.
It is. Depends heavily on the population risk. Chronic aspergillosis has an estimated incidence of about 10.4 new cases per 100,000 annually. Though the annual frequency for allergic fungal disease isn't precisely known, as it can develop at any age, typically in adulthood.
Okay.
Prevalence, which refers to the number of existing cases per 100,000, for chronic aspergillosis ranges from 1.4 to 126. Again, a wide range.
Huge range.
For allergic forms, specifically allergic bronchopulmonary aspergillosis, or ABPA, and severe asthma with fungal sensitization, or SAFS, the prevalence is approximately 286 per 100,000.
286. That's quite common then, relatively speaking.
Relatively, yes, especially among certain groups like those with asthma or CF. Now let's talk about the sheer scale. The total global burden is estimated at around 850,000 cases of invasive aspergillosis,
Wow.
approximately 3 million cases of chronic aspergillosis, and a remarkable 10 million cases of allergic aspergillosis worldwide.
10 million allergic cases. That's enormous.
These are indeed staggering numbers, painting a clear picture of a widespread, often underrecognized public health challenge.
Definitely.
There are also crucial geographic nuances worth noting. For instance, chronic granulomatous sinusitis is strikingly rare outside the Middle East and India.
Okay, very regional.
Very much so. Fungal or mycotic keratitis, that eye infection affecting the cornea, is particularly common in countries like Nepal, Myanmar, Bhutan, and India, although it certainly occurs globally.
Interesting hotspots.
Yeah. Chronic pulmonary aspergillosis, or CPA, presents a significant post-tuberculosis challenge, affecting about 6% to 13% of successfully treated pulmonary TB cases.
So after TB, this can pop up.
Exactly. And what's particularly tricky here, especially in regions with high TB prevalence, is that CPA can closely mimic smear-negative or clinically diagnosed tuberculosis, making accurate differentiation a real diagnostic hurdle.
A diagnostic mimic, basically.
Precisely. Finally, Aspergillus onychomycosis, a toenail fungus, has been reported anywhere from less than 1% to as high as 35% of all onychomycosis cases, and it's notably more common in individuals with diabetes, highlighting the role of underlying health conditions in susceptibility.
Diabetes again?
Yes. These regional differences underscore the complex interplay of local environmental conditions, genetic predispositions, and prevalent underlying health issues.
So with that global picture in mind, what does this all mean when we talk about who is truly most vulnerable to aspergillosis?
Well, the primary risk factors for invasive aspergillosis are conditions that profoundly compromise the immune system.
Right, the immune system.
We're talking about profound neutropenia, which is a dangerously low count of neutrophils, a type of white blood cell critical for fighting infection.
Okay, low white cells.
Then there's the use of glucocorticoids, commonly known as steroids, and also existing underlying respiratory disease.
Steroids and lung problems.
And the longer and more severe these conditions persist, the higher a patient's risk of developing invasive aspergillosis becomes.
Makes sense. Cumulative risk.
And here's a truly concerning paradox with glucocorticoids, which are often life-saving drugs.
Yeah.
Higher doses of these medications not only significantly increase a patient's risk of acquiring invasive aspergillosis in the first place, but they also markedly increase the risk of death from the infection if it occurs.
Wow, so they increase risk and worsen outcome if you get it.
Exactly. This is a critical and complex consideration for clinicians who must constantly weigh the benefits of these powerful anti-inflammatory drugs against this potentially fatal side effect.
Yeah.
It's a delicate tightrope walk in patient care.
A real clinical dilemma.
Building on that, beyond those primary well-recognized risks, deeper vulnerabilities also play a crucial role in determining who succumbs to invasive aspergillosis. We consistently see neutrophil and/or phagocyte dysfunction as a very important predisposing factor.
Okay, problems with those specific immune cells.
Precisely. This is evident in severe immune-compromised states like chronic granulomatous disease, advanced HIV infection, and relapsed leukemia, essentially. Conditions where the body's primary first responder immune cells are significantly impaired or non-functional.
Got it.
What's increasingly being recognized, especially if actively looked for, is the presence of invasive aspergillosis in medical intensive care unit patients, even those not typically thought of as profoundly immunocompromised.
So even in the ICU without classic immune issues.
Yes. The data here is quite compelling. It's been identified in 13% of patients with severe COVID-19 and in 1.3% to 3.9% of hospitalized patients with chronic obstructive pulmonary disease, or COPD.
13% in severe COVID. That's significant.
It is. This indicates that acute, severe illness, even without classic immune suppression, can tip the scales towards susceptibility.
Okay.
Other significant risk factors include extracorporeal membrane oxygenation, or ECMO, therapy, a highly invasive life support system that creates a unique vulnerability.
ECMO, right?
Also, temporary suppression of protective immune responses, whether it's from the necessary use of glucocorticoids, as you highlighted, or from what's called compensatory anti-inflammatory response syndrome. A systemic state where the body's own immune response is temporarily dialed down can significantly heighten the risk.
So the body's response itself can be a risk factor.
In a way, yes. Many patients who develop invasive aspergillosis also present with some evidence of prior pulmonary disease, most commonly a history of pneumonia or COPD. This pre-existing lung damage seems to create a more hospitable environment for the mold to take root.
Damaged lungs are more vulnerable.
Seems so. And in the era of modern medicine, many newer immunomodulating agents, drugs that modify the immune system, such as infliximab, which is used for autoimmune diseases, and ibrutinib, a chemotherapy drug, are unfortunately recognized for increasing this risk.
Modern medicine's double-edged sword again.
Indeed. Furthermore, severe liver disease and high levels of stored iron in the bone marrow have also been identified as contributing risk factors, highlighting the complex systemic interplay of underlying health conditions that can predispose someone to this infection.
That's a crucial point about the multifaceted nature of risk. Now let's shift our focus to chronic pulmonary aspergillosis, or CPA, because it presents with a distinct and somewhat surprising risk profile.
Right, CPA is different.
Patients with this form often have a wide array of underlying lung diseases that create a perfect niche for the fungus. This includes conditions like prior tuberculosis, a history of pneumothorax, a collapsed lung, or COPD.
Damaged lung structure again.
Exactly. But here's the interesting part. These patients are often apparently immunocompetent. They might not have the severe, obvious immune compromises we just discussed for invasive forms.
So they look okay immunologically on the surface.
Pretty much. Yet, when closely examined, they commonly have subtle defects in their natural killer cells, which are part of the innate immune system, or in the production of key immune signaling molecules like interleukin-12 or gamma interferon.
Subtle immune defects.
Right. Their inflammatory immune response, what we term a Th1-like response, is suboptimal, meaning it doesn't effectively clear the fungus, leading to typical persistent inflammation and disease.
So the immune system is trying, but not quite succeeding.
Precisely. And in this chronic form, unlike in acute situations where steroids are problematic, glucocorticoids can actually accelerate disease progression if not used cautiously and covered by antifungal therapy. It's a very delicate balance.
That's absolutely right. And then we have the allergic forms, which represent a completely different pathophysiological story, one defined by hypersensitivity.
The allergic side.
Allergic bronchopulmonary aspergillosis, or ABPA, usually develops as a complication of existing conditions like asthma and cystic fibrosis. There's a strong genetic predisposition for its development.
Genetics play a role here too.
A big role, with many identified genetic associations indicating a clear inclination towards a Th2-like or allergic immune response, specifically to Aspergillus fumigatus.
So a genetic tendency to overreact allergically to this specific mold.
Exactly. And here's another intriguing paradox. Despite the risks we discussed with glucocorticoids in invasive disease, high-dose glucocorticoid treatment for ABPA exacerbations almost never leads to invasive aspergillosis.
Really? That's fascinating.
It is. This stark difference truly highlights the distinct biological mechanisms at play between the invasive and allergic forms. They are essentially two very different battles against the same mold.
Different immune pathways entirely.
Pretty much. Fungal sensitization, and especially Aspergillus sensitization, is remarkably common in individuals with poorly controlled asthma. Furthermore, exacerbations of COPD, a chronic lung disease, have also been linked to Aspergillus sensitization, indicating its role in worsening existing respiratory conditions.
Makes asthma and COPD worse.
It can, yeah. It's also worth noting that most patients diagnosed with Aspergillus bronchitis have underlying bronchiectasis, that condition where the airways are abnormally widened, whether or not they also have cystic fibrosis. This structural change in the lungs seems to create a more hospitable environment for this persistent infection.
Bronchiectasis is a key setup for it.
Often, yes.
That brings us to a truly complex aspect, the genetic landscape of susceptibility. It's clear from the source material that it's not just about simple exposure of one obvious risk factor.
No, it's much more nuanced.
What's fascinating here is that different genetic traits are actually associated with the invasive, chronic, and allergic forms of aspergillosis. This means your individual genetic makeup plays a profound role in how your body might react to this ubiquitous mold.
Your genes determine your specific vulnerability type, in a way.
Exactly. The good news, and a real relief given how widespread Aspergillus spores are, is that the vast majority of people are probably not at significant risk for developing full-blown aspergillosis.
Thankfully.
However, the complex reality for those who are susceptible is that it appears multiple gene variants are necessary for susceptibility to each distinct form of aspergillosis.
So it's not just one gene.
No, this isn't a simple one gene, one disease scenario. Instead, it speaks to the intricate, multi-layered dance between our inherited genetics and the environmental factors we encounter. It's a truly personalized predisposition.
Indeed, understanding that intricate interplay is crucial for clinical practice. The Sources Table 217-2 provides a truly fantastic framework for conceptualizing the diverse ways aspergillosis can present.
Yeah, that table's helpful.
It categorizes the disease by the specific organ affected and by the type of infection, whether it's invasive, chronic, saprophytic, meaning the fungus lives on dead tissue without invading, or allergic.
Okay.
This detailed breakdown is immensely helpful in navigating the broad spectrum of manifestations we're about to delve into, allowing us to grasp the specific nuances of how this mold affects different parts of the body under varying conditions.
Let's start by exploring invasive pulmonary aspergillosis, or IPA, which is, importantly, the most common form of this disease.
Right, IPA is the big one.
The more compromised a patient's immune system is, the higher the frequency of invasive disease, and the more rapidly it tends to progress. So the weaker the immune system, the faster and more aggressive the infection typically becomes.
Makes intuitive sense.
IPA is usually classified as either acute, meaning its course is 1 month or less, or subacute, with a course of 1 to 3 months.
Acute or subacute?
A crucial detail is that over 80% of all invasive aspergillosis cases involve the lungs, and surprisingly, most of these are actually acquired out in the community, not just within hospitals.
80% in the lungs, mostly community acquired. That's important.
It is. The symptoms can be incredibly varied, which makes diagnosis difficult. They can range from absolutely no symptoms at all in some highly immunocompromised patients.
Really? No symptoms at all?
Apparently so. To a constellation of signs like fever, a cough that might sometimes be productive, non-specific chest discomfort, trivial hemoptysis that's coughing up small amounts of blood and shortness of breath.
Very nonspecific symptoms often.
Exactly. And it's vital to recognize a particularly misleading sign. Fever might initially respond to glucocorticoids, giving a false sense of improvement.
Ah, the steroid response masking things.
Precisely. But the underlying disease often continues to progress silently, making diagnosis particularly challenging because that initial improvement can mask the worsening condition. In patients who are on artificial ventilation, a critical diagnostic approach is to screen for Aspergillus antigen in tracheobronchial lavage fluid.
The BEL fluid test.
Right. This is a wash of the lungs obtained through a bronchoscope, and it's crucial for diagnosis because traditional radiology, like a chest x-ray, might not be distinctive enough to pinpoint the problem.
Radiology can be subtle, especially early on or in ventilated patients.
For at-risk patients, the keys to early diagnosis are a very high index of suspicion, screening for circulating antigen, especially in leukemia patients where the fungus can rapidly spread, and urgent CT scans of the thorax.
Suspect it, test for antigen, get a CT fast.
That's the mantra. It's a sobering fact that IPA is unfortunately one of the most common diagnostic errors revealed at autopsy, underscoring just how difficult it is to catch this rapidly progressive disease early enough.
Misdiagnosis leading to autopsy findings.
Yeah, that's sobering.
Now, let's talk about the radiological hallmarks that doctors look for. Figure 217-2 in the source provides some visual context for these. One of the most classic early signs, particularly in neutropenic patients, is called the halo sign.
The halo sign, yes.
This appears on a CT scan as a localized area of ground glass appearance, a hazy, indistinct density surrounding a nodule or a larger area of consolidation. This halo represents hemorrhagic infarction, meaning tissue death due to lack of blood supply combined with bleeding.
Okay, halo means bleeding around a dead spot.
Basically.
Okay.
This is a crucial early sign, typically present for about 7 days, and it's actually considered a good prognostic feature because its presence usually reflects an early diagnosis.
Early sign, better prognosis. Good.
However, an important caveat is that nodules with halo signs can also be seen in severe COVID-19 cases, so they don't by themselves definitively imply invasive aspergillosis without other supportive clinical and laboratory evidence.
Right, context is everything. COVID can cause similar signs.
Exactly. Other features seen on imaging can include nodules and pleural-based infarction, which is a wedge-shaped area of dead tissue near the lung lining, or cavitation, where a hollow space forms within the lung.
Nodules, infarcts, cavities.
Unfortunately, non-specific consolidation, which looks like a solid patch in the lung, is also very common, which can make it hard to differentiate from many other lung issues.
So it can look like regular pneumonia sometimes too.
It definitely can.
Beyond the lungs, invasive sinusitis is another significant manifestation of aspergillosis.
Sinus infections.
The sinuses are involved in about 5% to 10% of invasive aspergillosis cases, and this is particularly common in patients with leukemia and those who have received hematopoietic stem cell transplants, as their immune systems are severely compromised.
Leukemia and transplant patients, again, high risk.
Very high risk. Besides the usual fever, Common features include nasal or facial discomfort, a blocked nose, and sometimes even bloody nasal discharge. An endoscopic examination of the nose, where a thin lighted tube is inserted, can reveal pale, dusky, or even necrotic-looking tissue in the nasal passages or sinuses, which is a strong indicator.
Seeing dead tissue on endoscopy is a bad sign.
A very bad sign. While a CT or MRI of the sinuses is essential for diagnosis, early in the disease process, even these advanced imaging techniques might not be able to reliably distinguish invasive Aspergillus sinusitis from pre-existing allergic or bacterial sinusitis, adding a layer of complexity to the diagnostic challenge.
Imaging might not be clear early on.
Exactly. Sometimes Aspergillus infections are confined purely to the airways without invading the lung tissue directly. This condition is known as tracheobronchitis.
Just in the airways.
Right. The manifestations seen during a bronchoscopy, which is a procedure where a camera is inserted into the airways, can range quite broadly. From acute or chronic bronchitis, which is inflammation of the airways, all the way to more severe forms like ulcerative or pseudomembranous tracheobronchitis, characterized by the formation of a membrane in the airways.
Pseudomembranes. Sounds nasty.
It is. These airway-limited entities are particularly common among lung transplant recipients whose airways are highly vulnerable and patients who are on artificial ventilation.
Lung transplant and ventilated patients.
A significant and dangerous issue in these cases can be obstruction caused by thick mucus plugs. When this happens in immunocompromised patients, it's specifically termed obstructing bronchial aspergillosis, while in other patients, such as those with ABPA, it might be referred to simply as mucus impaction.
Mucus plugs blocking the airways.
Both can severely impair breathing and require urgent intervention.
Building on that, Aspergillus bronchitis presents with its own distinct set of features. Patients typically experience recurrent chest infections that only partially improve with standard antibiotic treatment, suggesting a non-bacterial cause.
Antibiotics don't fully work. Key clue.
Right. These infections are often associated with significant breathlessness or the coughing up of thick sputum plugs.
Coughing up plugs.
What's interesting about this patient profile is that they are generally not significantly immunocompromised in the way that patients with invasive forms are. Instead, they usually have underlying structural lung conditions like bronchiectasis,
Bronchiectasis again.
where the airways are abnormally widened and damaged, or cystic fibrosis, which creates a susceptible environment in the airways for the fungus to thrive.
So underlying lung structure is key here.
Seems to be. In occasional severe cases, patients can even present with acute respiratory failure due to severe airway obstruction from the sheer amount of mucus and inflammation.
Be life-threatening.
Definitely. It's also quite common for concurrent bacterial bronchitis to be present, which further complicates the clinical picture and treatment.
Fungal and bacterial together.
Yep. The diagnosis of Aspergillus bronchitis rests on the recurrent detection of Aspergillus in the airway, which can be identified through microscopy of sputum culture or highly sensitive PCR tests.
Finding the fungus repeatedly in sputum.
And additionally, Aspergillus IgG antibodies, that type of immune protein that indicates past or ongoing exposure, are usually detectable in these patients, providing another important diagnostic clue.
IgG antibodies positive too. Disseminated aspergillosis is a widespread and extremely dangerous threat, occurring in the most severely immunocompromised patients, often those with conditions like uncontrolled leukemia or late-stage AIDS.
Spreading everywhere.
Exactly. In these cases, Aspergillus spreads from its initial site, usually the lungs, to multiple organs throughout the body. The most common and devastating site for this dissemination is the brain, making it an especially grave complication.
Spreads to the brain, that's terrifying.
It is. However, it can also affect a wide array of other organs, including the skin, the thyroid gland, bones, kidneys, the liver, the gastrointestinal tract, the eye, manifesting as endophthalmitis, an infection inside the eye, and even heart valves.
Pretty much anywhere.
Pretty much. Aside from obvious skin lesions, the typical clinical picture involves a gradual but progressive clinical deterioration over 1 to 3 days, often accompanied by a low-grade fever and features that resemble mild sepsis, a severe whole-body response to infection.
Gradual decline, low fever, sepsis-like.
Laboratory tests might show non-specific abnormalities, making it hard to pinpoint. A critical insight here is that in most cases, at least one localized infection, a specific lesion in an organ, usually becomes apparent before the patient's death, highlighting the systemic nature of the disease and the fact that it often declares itself in different body parts.
So a specific spot often shows up eventually.
Usually, yes.
That makes perfect sense. The body is essentially being overwhelmed. And speaking of devastation, cerebral aspergillosis, as you just highlighted, is perhaps the most devastating complication of invasive aspergillosis.
Absolutely.
It almost always results from hematogenous dissemination, meaning the fungus spreads to the brain through the bloodstream. These lesions in the brain can be either single or multiple.
Brain lesions, single or multiple.
In acute disease, hemorrhagic infarction, which is tissue death due to a lack of blood supply combined with bleeding, is most typical, and cerebral abscesses, collections of pus in the brain, are common.
Blooding and abscesses in the brain.
Rarer manifestations include meningitis, an inflammation of the membranes surrounding the brain and spinal cord, mycotic aneurysms which are weakened, bulging blood vessel walls caused by the infection,
Fungal aneurysm.
and cerebral granulomas, which are small masses of immune cells that sometimes can tragically mimic a brain tumor on scans.
Can look like a tumor. Wow.
Local spread from the cranial sinuses, which are adjacent to the brain, can also occur, providing another pathway for brain involvement.
Spread from the sinuses nearby.
Rarely it develops after surgery, and this risk is significantly exacerbated by glucocorticoids, which are often given after neurosurgery to reduce inflammation. Again, highlighting that double-edged sword of steroid use we discussed earlier.
Steroids after neurosurgery increase risk.
The presentation can be either acute or subacute, with symptoms ranging from subtle mood changes to more overt focal neurological signs, seizures, and a general decline in mental status.
Mood changes, neurosigns, seizures decline.
For immediate investigation, MRI is the most useful imaging modality for the brain. An unenhanced CT scan of the brain is usually nonspecific, and the use of contrast dye for a CT or MRI is often contraindicated due to concerns about poor kidney function in these vulnerable, critically ill patients.
MRI is best. CT often not helpful without contrast, which might be risky.
Exactly. A specific risk factor that's been noted is that cerebral aspergillosis is disproportionately common in individuals on ibrutinib, a cancer drug used to treat certain blood cancers, underscoring how modern therapies can inadvertently create new vulnerabilities.
That drug, ibrutinib, is a specific risk factor. Interesting. Then there's endocarditis, which is heart involvement.
Infection in the heart.
Most cases of Aspergillus endocarditis are prosthetic valve infections, meaning they occur on artificial heart valves. This often results from contamination that takes place during the surgery itself, which is a critical point for surgical sterility.
Contamination during valve surgery.
However, native valve disease, meaning infection of the heart's natural valves, has also been reported, particularly as a feature of disseminated infection and in persons who use illicit intravenous drugs, where the fungus enters the bloodstream directly.
Native valves too, especially with 5E drug use.
The most common presentation for Aspergillus endocarditis is often a culture-negative endocarditis with large vegetations. These are masses of fungal material mixed with host cells that grow on the heart valves.
Big growths on the valves, but blood cultures are negative.
Often, yes. Interestingly, an embolectomy, which is the surgical removal of an embolus, a clot or piece of debris that has traveled through the bloodstream, can sometimes unexpectedly lead to the diagnosis when fungal material is found within the removed clot. This underscores the subtle nature of its presentation.
Finding it incidentally in a removed clot.
Occasionally, the dissemination of Aspergillus results in cutaneous features or skin manifestations. These typically appear as an erythematous, meaning red or purplish, non-tender area that gradually progresses to a necrotic eschar, which is a black, dead tissue crust.
Reddish area turning into a black crust on the skin.
Direct invasion of the skin can also occur in neutropenic patients, often at the site where an intravenous catheter is inserted, providing a direct entry point for the fungus.
Skin invasion at IV sites.
It's also commonly seen in burn patients, where the compromised skin barrier is highly vulnerable. Surgical, burn, and trauma wounds are also susceptible to infection with Aspergillus, especially Aspergillus flavus, highlighting the importance of wound care and environmental control in these settings.
Burns and wounds are vulnerable too. Now let's talk about chronic pulmonary aspergillosis, or CPA, which represents a significant long-term battle for many patients.
The chronic lung form, right?
The hallmark of chronic cavitary pulmonary aspergillosis, as visually represented in Figure 2.1701, is the presence of one or more pulmonary cavities that progressively expand over months or even years.
Expanding cavities over months to years.
These cavities are accompanied by persistent, often debilitating pulmonary symptoms like a cough and shortness of breath, as well as systemic manifestations such as profound fatigue and significant weight loss.
Lung symptoms plus fatigue and weight loss. Classic CPA.
A major challenge with CPA is that it's often initially mistaken for tuberculosis, especially in regions where TB is prevalent, which can significantly delay accurate diagnosis and treatment.
The TB mimic again.
A key predisposing factor. Over 90% of CPA cases occur in patients with pre-existing pulmonary disease that has already caused structural damage to the lungs.
90% have prior lung damage.
This includes conditions like prior tuberculosis, atypical mycobacterial infection, sarcoidosis, rheumatoid lung disease, a history of pneumothorax, collapsed lung, or even existing bullae, large air-filled sacs in the lungs, as well as previous lung surgery.
Lots of different kinds of previous lung damage.
The onset of CPA is typically insidious, meaning it develops gradually and subtly, and surprisingly, the systemic features like weight loss and fatigue may be more prominent than the pulmonary symptoms initially, further complicating early recognition.
Systemic symptoms might come first. Sneaky.
On a CT scan, typical findings that indicate active disease include an irregular internal cavity surface and thickened cavity walls. A minority of these cavities might show irregular material inside, a fluid level, and a well-formed fungal ball. That's the aspergilloma we'll discuss next.
Irregular, thick-walled cavities, maybe with a fungal ball inside.
Multiple cavities are actually more common than a single one, and they're typically found in the upper lobes of the lungs. Associated findings on imaging include pleural thickening, which is the thickening of the lining around the lungs, and pericavitary infiltrates, which are areas of inflammation surrounding the cavities, most obvious if a PET scan has been performed as part of the workup.
Multiple upper lobe cavities, pleural thickening, inflammation around them.
CPA is usually caused by Aspergillus fumigatus, but Aspergillus niger has been implicated, particularly in diabetic patients, and other species are rarely involved.
Usually fumigatus, sometimes niger in diabetics.
Diagnosis is strongly supported by the fact that IgG antibodies to Aspergillus are detectable in approximately 90% of CPA patients, indicating a chronic immune response to the fungus.
90% have positive IgG antibodies. Very helpful test.
It's also important to note that some patients can have concurrent infections, even without a fungal ball, with atypical mycobacteria and or other bacterial pathogens, making the clinical picture even more complex.
Oh, infections are common.
The most significant and potentially life-threatening complication of CPA is hemoptysis, which is coughing up blood, and this can even be the very first presenting symptom, often requiring urgent medical attention.
Coughing up blood. The big danger.
If left untreated, CPA progresses to what's termed chronic fibrosing pulmonary aspergillosis, or destroyed lung, an end-stage entity characterized by extensive irreversible fibrosis in one or both upper lobes of the lungs, severely compromising lung function.
Untreated, it destroys the lung with scar tissue. End-stage disease.
Grim outcome if untreated.
That terrifying potential for hemoptysis truly highlights the severity of chronic pulmonary aspergillosis. But within these chronic cases, there's a particularly striking manifestation that often gets its own mention. The aspergilloma, or fungal ball.
Yes, the fungal ball.
This is a specific and somewhat distinct finding, typically a later manifestation of chronic cavitary pulmonary aspergillosis, meaning it forms within pre-existing lung cavities. Interestingly, some patients with an aspergilloma can actually be completely asymptomatic despite its presence.
You can have a fungal ball and feel fine.
Sometimes, yes. The formation process involves the growth of the fungus inside a pulmonary cavity. This fungal growth then peels off, forming the characteristic layers that make up the spherical fungal ball.
Fungus grows, peels off, forms a ball.
For single or simple aspergillomas, the associated signs and symptoms are usually minor. These can include a cough, which may sometimes be productive, mild hemoptysis, wheezing, and mild fatigue.
Minor symptoms, usually with a simple fungal ball.
However, if a patient is experiencing more significant or debilitating symptoms, it usually indicates that there's underlying active chronic cavitary pulmonary aspergillosis, and the entire condition should be treated aggressively as such, rather than just focusing on the fungal ball itself.
Big symptoms mean treat the whole CPA, not just the ball.
Exactly. About 10% of fungal balls can resolve spontaneously, sometimes by being coughed up, but it's important to remember that even if the ball is gone, the underlying lung cavity may still be infected, and the patient may remain symptomatic.
Coughing it up doesn't mean you're cured.
Not necessarily. So resolution of the ball doesn't always mean resolution of the disease itself.
That distinction is so important. Another recently recognized form of chronic pulmonary aspergillosis is the Aspergillus nodule.
The nodule form.
This is quite significant because its appearance on imaging may closely resemble an early lung carcinoma, which obviously has major implications for diagnosis, patient anxiety, and the need for potentially invasive biopsies.
Looks like lung cancer. That's a huge issue.
These nodules can also cavitate, meaning a hollow space can form within them. They can be single or multiple, ranging in size from 5 to 50 millimeters in diameter, though larger mass lesions are rarely seen.
Single or multiple nodules can cavitate.
On imaging, these nodules are usually avid on positron emission tomography or PE scans, meaning they light up brightly, which is another characteristic that can sometimes mimic malignancy.
Bright on PD scan, also like cancer.
For diagnosis, IgG antibodies to Aspergillus are detectable in approximately 65% of patients with an Aspergillus nodule, providing a crucial serological clue to differentiate it from cancer.
IgG antibodies positive in about 2/3 helps tell it apart from cancer.
Very useful clue.
When we talk about chronic Aspergillus sinusitis, it's actually a broad designation that encompasses 3 distinct clinical entities, each with its own characteristics and implications.
Okay, 3 types of chronic sinus issues.
First, we have the fungal ball of the sinus. This condition is primarily limited to the maxillary sinus, which is located in your cheekbones, although it rarely involves the sphenoid sinus, which is deeper in the skull. In this scenario, the sinus cavity is quite literally filled with a fungal ball, composed of dense fungal growth.
Fungal ball just sitting in the sinus.
Pretty much. Maxillary disease in particular is often linked to prior upper jaw root canal work and existing chronic bacterial sinusitis.
Root canals can predispose. Interesting.
Seems so. On CT scans, about 90% of cases show focal hyperattenuation, which are bright areas related to concretions or hardened masses within the sinus. On MRI, a specific sequence called the T2 weighted signal is decreased, which is a key differentiator because it's typically increased in bacterial sinusitis, giving doctors a unique fingerprint to distinguish it.
Specific CT and MRI signs help differentiate it.
Crucially, surgical removal of the fungal ball is typically curative for this condition, and no tissue invasion is demonstrable histologically or radiologically, meaning it's a localized, non-invasive mass.
Surgery cures it, no invasion. Good prognosis then.
Generally, yes for this type. In contrast, chronic invasive sinusitis is a slowly destructive process.
Okay, this one sounds worse. Invasive.
It is. This more aggressive form most commonly affects the ethmoid and sphenoid sinuses, which are complex air-filled spaces deep within the skull. Patients are usually, but not always, immunocompromised to some degree, for example, due to diabetes or HIV infection.
Often some immune compromise destroys tissue slowly.
Imaging of the cranial sinuses shows widespread opacification, meaning the sinuses are filled with material, along with clear evidence of local bone destruction and invasion of surrounding structures, such as the eye socket or brain.
Destroys bone, invades nearby structures.
The differential diagnosis for this condition is wide, including various other infections and even cancers. Besides a history of chronic nasal discharge and blockage, loss of the sense of smell, and persistent headache, the usual presenting features often relate to local involvement of critical structures. A classic and severe example is the orbital apex syndrome, which can lead to blindness and proptosis, or bulging of the eye due to the infection extending into that area.
Can cause blindness and bulging eyes. Serious complication.
Very serious. Finally, there's chronic granulomatous sinusitis. This is most commonly seen in the Middle East and India, and is often caused by Aspergillus flavus.
The regional one again, flavus cause.
This condition typically presents late, with noticeable facial swelling and unilateral proptosis. What histologically distinguishes this disease from chronic invasive sinusitis is the prominent granulomatous reaction, meaning the body forms organized clumps of immune cells to wall off the infection.
Granulomas, the body trying to wall it off.
Exactly. Whereas chronic invasive sinusitis typically shows extensive tissue necrosis or cell death with only a low-grade mixed cell infiltrate. IgG antibodies to Aspergillus flavus are usually detectable in these patients, providing a valuable serological tool for diagnosis.
Granulomas on biopsy and positive flavus antibodies help diagnose this type.
Precisely.
Switching gears significantly to the allergic responses, we have allergic bronchopulmonary aspergillosis, or ABPA.
ABPA, the allergic lung reaction.
In almost all cases, ABPA represents a type hypersensitivity reaction, essentially a severe allergic response, primarily to Aspergillus fumigatus. Rare cases can be due to other Aspergilli or even other fungi, but fumigatus is the main culprit.
Allergic reaction to fumigatus usually.
This condition occurs in approximately 2.5% of asthma patients who are referred to specialized care, though its prevalence may be less common in the United States and more common in those from the Indian subcontinent, possibly due to genetic factors or exposure patterns.
2.5% of referred asthma patients. Quite specific numbers.
In individuals with cystic fibrosis, a genetic disorder affecting mucus production, up to 15% of teenagers are affected, making it a significant and debilitating complication in that population.
15% in teens with CF. A big problem for them.
Patients with ABPA typically experience episodes characterized by bronchial obstruction due to thick mucus plugs, leading to severe coughing fits, what might be described as pneumonia, areas of consolidation in the lungs, and significant breathlessness. Many patients actually report coughing up thick sputum casts, which are often described as being brown in color, which is a telltale sign of this condition.
Airway obstruction, coughing fits, brown plugs. Very characteristic.
In terms of lab work, eosinophilia, a high eosinophil count in the blood, commonly develops, especially before systemic glucocorticoids are administered, as steroids suppress this allergic immune response.
High eosinophils in the blood.
The cardinal diagnostic test for ABPA is the detection of Aspergillus-specific IgE antibodies, or a positive skin prick test response to A. fumigatus extract, along with a significantly elevated serum level of total IgE, usually greater than 1,000 IU/ml, which indicates a heightened allergic state.
Specific IgE, positive skin test, and very high total IgE, over 1,000. Key tests.
On imaging, the presence of hyperattenuated mucus in the airways, meaning the mucus appears unusually dense and bright on a CT scan, is highly specific for ABPA.
Dense mucus on CT. Specific sign.
Bronchiectasis, which is a permanent and irreversible widening of the airways, is characteristic in these patients, and some patients may even develop chronic cavitary pulmonary aspergillosis over time as a long-term complication.
Causes bronchiectasis and can even lead to CPA later on.
Yeah, long-term risk.
Building on that, severe asthma with fungal sensitization, or SAFS, is a related but distinct allergic condition that often gets overlooked.
SAFS. Similar but different.
Many adults who suffer from severe, difficult-to-control asthma don't meet the full diagnostic criteria for ABPA, but they are nonetheless highly allergic to fungi.
Severe asthma, allergic to fungi, but not quite ABPA.
Right. While Aspergillus fumigatus is certainly a common allergen implicated in SAFS, numerous other fungi, such as Cladosporium and Alternaria species, are also implicated, identified through skin prick testing and for specific IgE testing, meaning the allergic trigger can come from a variety of environmental molds.
Can be allergic to other molds too, not just Aspergillus.
The key lab finding that helps distinguish SAFS from ABPA is that serum total IgE concentrations in SAFS patients are typically less than 1,000 IU/ml, which is a lower threshold than what's usually seen in ABPA.
Total IgE is high, but usually under 1,000. Helps differentiate.
On imaging, bronchial wall thickening is a common feature, indicating chronic inflammation in the airways. Collectively, ABPA and SAFS are often referred to under the umbrella term fungal asthma, reflecting their shared underlying allergic response to fungal antigens and the significant impact fungi can have on asthma severity.
Fungal asthma. Good umbrella term. Just like the lungs, the sinuses can also manifest allergic responses to Aspergillus and other fungi, leading to allergic fungal rhinosinusitis.
Allergic reaction in the sinuses now.
Affected patients present with chronic, meaning persistent and long-standing, sinusitis that is notably unresponsive to standard antibiotic treatment, which is a key clinical clue.
Chronic sinusitis, antibiotics don't work.
Many of these patients develop nasal polyps, which are soft, painless, non-cancerous growths inside the nasal passages, and all of them have congested nasal mucosae, the lining of the nose and sinuses that are full of thick mucoid material.
Nasal polyps and sinuses full of thick mucus.
When examined histologically, meaning under a microscope, the hallmarks of allergic fungal rhinosinusitis are local eosinophilia, which is a high concentration of eosinophils.
Eosinophils again.
A type of white blood cell strongly associated with allergic reactions, and the presence of Charcot-Leyden crystals. These are microscopic needle-shaped crystals formed from the breakdown products of eosinophils, confirming that allergic inflammation is indeed at play.
Eosinophils and Charcot-Leyden crystals on biopsy confirm the allergic nature.
Treatment typically involves the surgical removal of this abnormal mucus and polyps, combined with local and occasionally systemic administration of glucocorticoids, which usually leads to resolution of the condition by dampening the allergic response.
Surgery to remove mucus and polyps plus steroids.
However, persistent or recurrent signs and symptoms may necessitate more extensive surgery, such as an ethmoidectomy, which is the surgical removal of bone and tissue from the ethmoid sinuses, and sometimes even oral antifungal therapy. Sadly, recurrence in allergic fungal sinusitis is common, often triggered after another bacterial or viral infection, which can reactivate the allergic inflammation.
Recurrence is common, might need more surgery or antifungals.
A persistent problem for some.
Finally, we have superficial aspergillosis, which, as the name suggests, manifests on the surface of the body without deep tissue invasion.
On the surface.
There are three main presentations here. Keratitis, which is an infection of the cornea, the clear outer layer of the eye, onychomycosis, commonly known as a nail fungus, particularly affecting toenails, and otitis externa, an infection of the outer ear canal, often called swimmer's ear.
Eye, nail, and ear infections.
Keratitis caused by Aspergillus can be particularly challenging to diagnose early enough to save the patient's sight, making prompt recognition critical. The optimal therapy for fungal keratitis typically involves natamycin 5% eye drops as a specific antifungal medication, often combined with surgery to achieve the best outcome and preserve vision.
Fungal keratitis needs fast diagnosis, specific eye drops, maybe surgery?
As for otitis externa, it usually resolves quite well with debridement, which is the removal of infected debris and tissue, and the local application of antifungal agents, making it generally less severe than the other forms we've discussed, but still requiring specific treatment.
Ear infection usually responds well to cleaning and local antifungals. So, with all these varied presentations in mind, let's turn to the diagnostic quest. How do we actually find Aspergillus in the body? What's fascinating here, and something you'll notice underscored in Table 217-1 of our source, is that establishing a confident diagnosis for any form of aspergillosis rarely relies on a single test.
No silver bullet test.
No. Instead, it requires a multifaceted approach, combining various techniques and clues to paint a complete picture. It's truly a detective story for clinicians.
That's absolutely right. And for acute invasive aspergillosis, it's truly a race against time for diagnosis and treatment.
Time is critical.
Patients with this aggressive form typically have a relatively heavy load of fungus in the affected organ, which means diagnostic tools like antigen detection, PCR, microscopy, culture, and/or histopathology usually provide confirmation.
Lots of fungus means tests are usually positive.
Usually. However, the rapid pace of progression leaves only a very narrow window for making the diagnosis without losing the patient. And unfortunately, some invasive diagnostic procedures, like lung biopsies, might even be impossible due to existing critical conditions, like coagulopathy.
Blood clotting problems.
Right, or severe respiratory compromise, or other factors unique to critically ill patients. This is why many cases of invasive aspergillosis are tragically missed clinically and are only diagnosed at autopsy, a stark reminder of the diagnostic challenge.
Biopsies might be too risky, leading to misdiagnoses.
Exactly. Histologic examination of affected tissue, meaning looking at a tissue sample under a microscope, reveals distinct features. Doctors will typically see either infarction, which is tissue death due to lack of blood supply, often with invasion of blood vessels by many fungal hyphae, the thread-like structures of the fungus, or acute necrosis, characterized by widespread cell death with limited inflammation and fewer hyphae.
Tissue death with fungus invading blood vessels, or just tissue death with fungus nearby.
Aspergillus hyphae themselves are quite distinct. They're described as hyaline, meaning clear or glass-like, narrow and septate, meaning they have internal divisions, and they branch at a characteristic 45-degree angle. Importantly, no yeast forms are present, which helps differentiate it from other fungal infections like candidiasis.
Clear, narrow, spet hyphae branching at 45 degrees. No yeast. Very specific look.
Regarding antigen tests, one common test detects galactomannan, a polysaccharide, which is a type of sugar molecule released by Aspergillus organisms during active growth. Another test detects a novel protein antigen.
Galactomannan and a protein antigen test.
Antigen detection in respiratory samples, like bronchoalveolar lavage fluid, is more sensitive than in serum, the liquid part of blood, and is particularly critical in intensive care unit patients where radiology might be nonspecific or misleading.
Testing lung fluid is better than blood, especially in ICU.
Positive serum antigen results often precede clinical or radiological features by several days, which can be a valuable early warning sign, allowing for earlier intervention.
Positive blood antigen can be an early warning.
However, it's important to note that the sensitivity of antigen detection is significantly reduced if the patient is already on antifungal therapy.
Antifungals make the antigen test less reliable.
While a positive culture of Aspergillus from a patient sample supports the diagnosis, given that multiple other rarer fungi can mimic Aspergillus species histologically, it's important to know that only 10% to 30% of patients with invasive aspergillosis actually have a positive culture.
Culture is only positive 10–30% of the time. Not very sensitive.
Not very. It's also critical to note that standard bacterial agar, which is routinely used in labs, is less sensitive than specific fungal media for culture. So if a fungal culture isn't specifically requested by physicians, the diagnosis can easily be missed.
Need to specifically ask for fungal culture media.
High-volume fungal cultures, meaning culturing a larger amount of sample, can significantly enhance the yield. A positive culture, though, might also represent non-invasive forms of aspergillosis, or simply airway colonization, where the fungus is present but not actively invading, so it must always be interpreted carefully within the broader clinical context.
Positive culture doesn't automatically mean invasive disease. Context matters.
Always. Both antigen detection and real-time PCR, a molecular test that detects fungal DNA, are faster and much more sensitive than culture of respiratory samples and blood, offering crucial advantages in time-sensitive, life-threatening situations.
Antigen and PCR tests are faster and more sensitive than culture. Key advantage.
For definitive confirmation of a diagnosis of invasive aspergillosis, specific criteria must be met. This typically requires either one, a positive culture of a sample taken directly from an ordinarily sterile site, such as a brain abscess, or two, positive results from both histologic testing and culture, or molecular confirmation of Aspergillus species from a sample taken from an affected organ like the sinuses or skin.
Definitive diagnosis needs culture from a sterile site, or histology plus culture PCR from the affected organ. High bar.
It is. However, in real-world clinical practice, most diagnoses of invasive aspergillosis are inferred from fewer data due to the rapid progression and patient fragility. This often includes the presence of the halo sign on a thoracic CT scan, which, as you mentioned, is a localized ground glass appearance representing hemorrhagic infarction surrounding a nodule or consolidation.
Most diagnoses are inferred, often based on things like the halo sign.
These halo signs are typically present for about 7 days early in the course of infection in neutropenic patients and are considered a good prognostic feature indicating an early diagnosis. But it's vital to remember that nodules with halo signs can also be a feature of COVID-19, and they do not, by themselves, imply invasive aspergillosis without other supportive evidence.
Halo sign is suggestive but not definitive, especially with COVID around.
Other characteristic radiological features of invasive pulmonary aspergillosis include nodules and pleural-based infarction or cavitation, although non-specific consolidation is, unfortunately, also very common, further complicating early diagnosis.
Nodules, infarcts, cavities are characteristic, but non-specific consolidation is common too. Still challenging. That deep dive into diagnostics really highlights the challenges, especially with the rapid progression of invasive forms. But for chronic aspergillosis, the diagnostic approach is a bit different and often less invasive as the disease progresses more slowly.
Right, chronic is a bit different diagnostically.
Here, Aspergillus antibody testing, specifically IgG antibodies, combined with characteristic imaging findings on CT scans, is generally sufficient for diagnosis.
IgG antibody plus CT scan is often enough for chronic forms.
If a biopsy of an Aspergillus nodule is performed, which is sometimes necessary to rule out cancer, it would typically reveal hyphae surrounded by cells of chronic inflammation and sometimes even granulomas, those organized clumps of immune cells we mentioned earlier.
Biopsy shows fungus with chronic inflammation, maybe granulomas.
Antibody titers, which are measurements of the antibody levels in the blood, are also helpful for monitoring therapy because they tend to fall slowly with successful treatment, indicating the patient is responding.
Antibody levels go down with successful treatment. Good monitoring tool.
Cultures, while possible, are infrequently positive in chronic forms, but they are important if obtained, especially for checking for azole resistance, which is a growing concern.
Culture is rare, but important for resistance testing if you get it.
Real-time PCR of sputum samples, looking for the fungus's genetic material, is often strongly positive in these cases.
Sputum PCR is often positive in chronic forms.
And interestingly, some patients with chronic pulmonary aspergillosis also have elevated titers of total serum IgE and Aspergillus-specific IgE, highlighting that potential overlap in immune responses with the allergic forms we discussed earlier.
Some overlap with allergic markers, IgE, even in chronic disease. Interesting.
Yeah, the body's response can be complex.
And when it comes to the allergic forms like ABPA and ZAFS, the diagnosis is primarily serological, meaning it's based on blood tests. Here we're looking for elevated specific and total serum IgE levels. These are markers of an allergic immune response, or relying on positive skin prick tests, where a tiny amount of Aspergillus extract is pricked into the skin to see if an allergic reaction occurs.
Allergic forms diagnosed mainly by IgE blood tests or skin tests.
For allergic Aspergillus sinusitis, the diagnosis is usually made histologically by examining tissue samples for characteristic signs, and this is often accompanied by the detection of Aspergillus IgE antibodies, further confirming the allergic nature of the inflammation.
Allergic sinusitis needs biopsy plus IgE tests.
So for the allergic conditions, the precise immune response is often the key to unlocking the diagnosis.
So with all these complex manifestations and diagnostic pathways, what does this all mean for treatment? The good news is that there's a robust arsenal of antifungal drugs active against Aspergillus.
We do have drugs, thankfully.
These include well-known agents like voriconazole, itraconazole, posaconazole, and isofluconazole, which are all from the azole class of antifungals,
The azoles.
as well as echinocandins like caspofungin and micafungin, and also amphotericin B, often referred to as A and B.
Echinocandins and amphotericin B2, several classes.
However, there are crucial considerations that practitioners must carefully weigh, especially with azoles, due to their significant potential for drug interactions with other medications a patient might be taking, which can be quite complex to manage.
The Zoli drug interactions are a major headache.
They really are. Furthermore, plasma azole concentrations, the amount of drug in the patient's bloodstream, can vary widely from one patient to another, impacting effectiveness and safety.
Levels can be all over the place.
Because of this, many authorities recommend monitoring these levels to ensure that drug concentrations are not only effective in fighting the fungus, but also remain within a non-toxic range, particularly for itraconazole and voriconazole.
Monitoring drug levels is often necessary, especially for Entra and Vori.
As for administration routes, initial intravenous administration is preferred for acute invasive aspergillosis due to its severity, whereas oral administration is typically used for other forms that require ongoing antifungal therapy.
40 first invasive, then often switch to oral. Oral for chronic allergic.
The Sources Table 217-3 provides detailed recommendations for various situations, which are critical guidelines for medical professionals navigating these complex treatment decisions.
Indeed, understanding the specifics of each treatment agent is vital. For invasive aspergillosis, voriconazole, isovuconazole, and posaconazole are considered the preferred primary agents.
Vori, Isa, Posa are first line for invasive.
Studies have consistently shown they actually demonstrate a 20% higher response rate and improved survival compared to amphotericin B as primary therapy.
Better survival than Ampho B significant.
Second-line agents used if the first line fails or isn't tolerated include caspofungin, micafungin, and lipid-associated forms of amphotericin B, which are less toxic than the conventional form.
Echinocandins and lipid Ampho B are second line.
It's crucial to note specific drug limitations. For instance, amphotericin B is not active against Aspergillus terreus or Aspergillus nigilans, so using it for those species would be ineffective.
Ampho B doesn't work for terrorists or nigilans. Critical point.
Also, while multi-azole resistance in Aspergillus fumigatus is present, though still uncommon, it's a growing concern globally. And specifically, Aspergillus niger is naturally resistant to both itraconazole and isovuconazole, which is a key distinction when selecting initial therapy.
Azole resistance is emerging, and Niger is resistant to Itra and Isa. Need to know the species.
Absolutely. Given this complexity, the management of invasive disease really necessitates an infectious disease consultation from a specialist.
Definitely need an ID expert involved.
While immune reconstitution, the recovery of the patient's immune system, is absolutely essential for a patient's long-term recovery, it can sometimes paradoxically complicate the initial process as the immune system starts to react more robustly to the lingering fungal elements.
Immune recovery is good, but can cause temporary worsening sometimes.
The duration of therapy for invasive aspergillosis is highly variable, ranging from approximately 3 months to several years, depending on the patient's underlying immune status and their response to treatment.
Treatment can be months to years. Very variable.
Relapse can certainly occur if the initial response to therapy is suboptimal and immune reconstitution is not complete, underscoring the need for prolonged monitoring.
Relapse is a risk if immunity doesn't fully recover. When we look at chronic and allergic forms of aspergillosis, the management shifts to a more long-term approach, often requiring sustained therapy.
Longer-term treatment for these.
For chronic aspergillosis, voriconazole is currently the preferred oral agent. Itraconazole or posaconazole are often used as substitutes if treatment with voriconazole fails, if resistance to voriconazole emerges, or if adverse events occur that make it intolerable for the patient.
Vori is preferred for chronic, with Itra or Posa as backups.
For chronic cavitary pulmonary aspergillosis in particular, response to therapy is notoriously slow, necessitating treatment for over 6 months, and in many cases, disease control may actually require years of continuous treatment.
CPA responds slowly. Need treatment for 6+ months, maybe years.
For other chronic and allergic forms, the duration of treatment requires a careful, individualized, case-by-case evaluation. It's important to remember that glucocorticoids, if used in chronic cavitary pulmonary aspergillosis, should only be administered if the patient is concurrently covered by adequate antifungal therapy, due to the risk of accelerating disease progression we discussed earlier.
Steroids and CPA need antifungal cover. Critical rule.
Acute exacerbations of ABPA generally respond well to voriconazole, itraconazole, or a short course of glucocorticoids. Long-term azole therapy typically helps to minimize corticosteroid exposure and maintain remission, reducing the patient's reliance on potentially problematic steroids.
ABPA flares respond to antifungals or short steroid bursts. Long-term azoles help reduce steroid need.
For Aspergillus bronchitis, the antifungal response is often quite gratifying, meaning patients improve significantly and rapidly. However, relapse after about 4 months of therapy is common, indicating the need for careful long-term monitoring and potentially prolonged courses of treatment to prevent recurrence.
Aspergillus bronchitis responds well initially, but relapse is common after stopping treatment around 4 months.
Need longer treatment, maybe.
A significant and growing concern in the field, and one that has broader public health implications, is the challenge of resistance.
Resistance, big topic.
Resistance in Aspergillus fumigatus to one or more azoles, while still uncommon, is increasingly being found globally. What's particularly fascinating and a critical environmental link is that this resistance may actually be derived from the widespread use of azole fungicides in agriculture, specifically in crops.
Resistance coming from farm fungicides, that's huge.
It's a major hypothesis and concern. This suggests a clear environmental connection between agricultural practices and the emergence of drug-resistant human pathogens.
Environmental resistance.
In addition, resistance can also develop during long-term treatment in individual patients through multiple mechanisms, often due to selective pressure on the fungus. A positive culture of Aspergillus from a patient who is already undergoing antifungal therapy is a clear and urgent warning sign that this treatment-induced resistance has emerged, necessitating an immediate change in therapeutic strategy to prevent treatment failure.
Resistance can also develop during treatment. Positive culture while on therapy is a red flag.
A big red flag.
That environmental link to resistance is a truly thought-provoking point. Beyond medication, surgery plays a crucial role in several forms of aspergillosis.
Surgery has its place too.
It can be curative for conditions like a fungal ball of the sinus, and for single aspergillomas, those fungal balls in lung cavities.
Curative for fungal balls, sinus and lung.
It's also an important intervention for invasive aspergillosis involving bone, heart valves, sinuses, and specific localized areas of the lung, particularly if there's a risk of catastrophic hemoptysis, that life-threatening bleeding.
Important for invasive disease in bone, heart, sinus, or parts of the lung at risk of bleeding.
Surgery is also vital for managing brain abscesses, keratitis in the eye, and endophthalmitis, an infection inside the eye.
Also for brain abscess, eye infections.
In allergic fungal sinusitis, the surgical removal of abnormal mucus and polyps, combined with local and occasionally systemic glucocorticoid treatment, usually leads to resolution. However, persistent or recurrent signs and symptoms may necessitate more extensive surgery, such as an ethmoidectomy.
Right, surgery for allergic sinusitis too.
Which is the surgical removal of infected bone and tissue from the ethmoid sinuses, and sometimes even oral antifungal therapy. Unfortunately, recurrence in allergic fungal sinusitis is common, often triggered after another bacterial or viral infection, which can reactivate the allergic inflammation.
Recurrence is common, might need bigger surgery.
It's worth noting, though, that surgery is often problematic and carries high risks in chronic cavitary pulmonary aspergillosis, usually resulting in serious complications due to the underlying lung damage.
Surgery for CPA is risky, high complication rate.
For problematic hemoptysis, bronchial artery embolization, a minimally invasive procedure that blocks blood vessels, is generally preferred over major surgery for managing the bleeding, offering a safer alternative.
Embolization is preferred for bleeding in CPA, safer than surgery. Finally, let's discuss prophylaxis, which is the strategic use of antifungal agents to prevent infection in high-risk individuals.
Preventing infection in the first place.
This is generally accepted and practiced in situations where there's a moderate or high risk of infection, for example, after induction chemotherapy for acute myeloid leukemia, where the immune system is severely suppressed.
Used for high-risk situations like leukemia chemo.
The goal here is to provide broad protection, covering both superficial and systemic candidiasis, which is a yeast infection, as well as invasive aspergillosis. It's important to highlight a critical point. Fluconazole, which is commonly used in these situations for other fungal infections, has no activity against Aspergillus species, so it wouldn't be effective for preventing aspergillosis.
Fluconazole doesn't cover Aspergillus. Very important point.
More effective options include itraconazole solution or subiatraconazole capsules, which offer modest efficacy due to better bioavailability, meaning the drug is absorbed more effectively by the body, with the latter having fewer adverse events. Posaconazole tablets have demonstrated even greater effectiveness in reducing infection rates and the need for empirical antifungal therapy, which is treatment given when an infection is suspected but not yet confirmed.
Itraconazole is okay. Posaconazole is better for prevention.
Some data also support the use of intravenous micafungin and echinocandin for individuals who have contraindications or cannot tolerate azole medications. However, it's crucial to understand that no prophylactic regimen is completely successful in preventing all infections, so vigilance remains key.
K4-me micafungin is an option too, but nothing is 100% effective.
Correct.
Looking at the outcomes across the spectrum of aspergillosis, it's truly a mixed picture, reflecting the complexity of these diseases and the patient factors involved.
Outcomes vary a lot.
For invasive aspergillosis, the good news is that it is indeed curable if immune reconstitution occurs if the patient's immune system recovers sufficiently. If the infection is treated, the mortality rate ranges from 30% to 70%, which is still high but offers a chance of survival.
Curable if immunity recovers.
Yeah.
Mortality 30-70% if treated. Still high.
However, and this is a profound and tragic point, if the diagnosis is missed entirely, the mortality rate is a devastating 100%.
Misdiagnosis equals 100% mortality. Stark.
Certain forms carry a very poor prognosis, almost invariably leading to a fatal outcome. This includes cerebral aspergillosis, Aspergillus endocarditis, and bilateral extensive invasive pulmonary aspergillosis.
Brain, heart, extensive lung disease have very poor outcomes.
Similarly, invasive infection in persons with late-stage AIDS or relapse, uncontrolled leukemia also carries extremely poor outcomes, highlighting the critical role of a functioning immune system.
Very poor outcomes in late AIDS or uncontrolled leukemia too. Immunity is key.
For chronic cavitary pulmonary aspergillosis, or CPA, despite active and often prolonged treatment with antifungal agents, the mortality rate is approximately 40% over 5 years and 50% to 60% over 10 years.
CPA mortality is high even with treatment, 40% at 5 years, 50-60% at 10 years.
This underscores the persistent, challenging nature of this chronic disease. A sobering statistic is that if a patient goes 12 months without any antifungal therapy, a staggering 70% of them will clinically deteriorate and between 10% and 35% will die.
Untreated CPA, 70% worsen, 10-35% die within a year. Treatment is vital.
Even with therapy, treatment fails in about 30% of recipients of antifungal therapy, and the failure rate is even higher if the disease is left untreated.
Treatment fails in 30% even with antifungals. Tough disease.
For allergic forms like ABPA and CFS, patients generally respond well to antifungal therapy, which is encouraging.
Better news for allergic forms.
Approximately 60% respond to itraconazole, and about 80% respond to voriconazole and posaconazole, provided these medications are tolerated. Inhaled amphotericin B is also effective and tolerated by about 15% of patients.
Good response rates to antifungals, 60-80% for Zols.
A significant positive outcome of this treatment is that if the severity of asthma declines, the inhaled glucocorticoid dose can often be safely reduced, and oral glucocorticoids can even be stopped, improving the patient's overall quality of life and reducing steroid side effects.
Can reduce or stop steroids if asthma improves. big benefit.
However, relapse after discontinuation of therapy is common, though not universal, indicating the need for ongoing vigilance and a personalized approach to long-term management.
Relapse is common after stopping therapy for allergic forms, though. Needs monitoring.
So what does this all mean for you, our listener? We've taken a truly comprehensive deep dive into Aspergillosis, unearthing its diverse manifestations, from invasive to chronic and allergic forms.
Covered a lot of ground.
We've explored the complex interplay of ubiquitous environmental factors and varied patient vulnerabilities, and the nuanced, often challenging approaches to diagnosis and treatment. You now have, I hope, a foundational understanding that goes far beyond surface-level information, hopefully giving you that aha moment of clarity where the pieces of this complex medical puzzle truly come together, equipping you with the insights of an elite professional in this intricate field.
Hopefully demystified it a bit, despite the complexity.
Exactly.
This raises an important question, I think. Given the truly ubiquitous presence of Aspergillus spores in our environment, they're literally everywhere, inside and outside, and the increasing recognition of this infection in both deeply immunocompromised and seemingly immunocompetent individuals. What broad public health strategies and architectural or design considerations for our living and working spaces, beyond just the highly controlled environments of hospitals, might we need to consider to mitigate these often unseen risks?
That's a great question. Beyond hospitals, what about homes, offices, schools?
Right. It pushes us to think about how our understanding of this mold should influence everyday environments.
Yeah.
Are we thinking enough about indoor air quality, mold remediation, building design?
We encourage you to think about these questions, to perhaps notice the discussions around air quality, dampness, or respiratory health with a new, informed perspective. Thank you for diving deep with us. Until next time, keep exploring, keep learning, and keep questioning.